Hello, future nurses. We are going to touch base very quickly on Unit 4. And Unit 4, we start off with stress response and stress management. This is often something that y'all are very familiar with because it is so super common. And one that you might be familiar with, one of our stress theories is Cannon's theory of fight or flight. And in this, it's our body's way to prepare for a situation when we receive a threat to our survival. In this sense, when we're fighting, when it's going on, our blood pressure is increasing, our heart rate is increasing, our respirations are increasing, our cardiac output is increasing. And do we fight the lion or do we run away from the lion? We do see that some individuals may freeze. They don't know what to do. Is fighting the best option or is freezing the best option? Some animals may also become frozen to avoid being seen. Another one of our early stress response theories is called the general adaptation syndrome. And this very much incorporated that fight or flight into a little expanded theory. And we have 3 stages. The alarm stage is the initial. It's very brief. It's adaptive. It's very much that fight or flight. And we have a lot of our body interacting. So like the hypothalamus gets aroused, and it's going to signal our autonomic nervous system to start working faster. And when that happens, we're going to see that increase in pulse. Our pupils are going to dilate. We're going to have increased blood production during this time to be able to give us extra energy. Blood moves away from the digestive tract, so we wind up with dry mouth. As it subsides, we start to see the adrenal gland get activated, and it just really keeps us going to produce that extra cortisol, to increase blood glucose, to just be able to keep us moving. If the threat subsides, the body goes to rest and it all kind of stops. If the threat continues, we move into what is called the resistance stage. And the resistance stage is when resistance to the stressor occurs. Recovery, repair, renewal may happen at this time. Right, our blood pressure is now decreasing, our respirations are decreasing, our hearing is kind of getting a little bit dulled down because during that alarm stage, we actually have some extra superpower hearing to be able to be more aware of our surroundings. As we get into the resistance stage, we've used up resources, we've reduced our defenses, we've reduced our energy. And if the stressor continues through the resistance stage and we remain in the state of arousal, we go to the final stage, which is exhaustion. And at this point, we can't resist the stressor. Our resources are completely depleted. The crest becomes chronic. And when we look at the long-term overexposure to that cortisol that was being released, we become more vulnerable to illness. So one thing we have to think about is we do have something called eustress. We tend to be aware of distress, but we forget that good things can still be stressful. So distress is when we get, you fail a test, you have a death in the family, work and school, financial overload. Eustress, however, though they're positive, they can still tax the system. One of the examples I always give is if you go win the lottery. We see these people who win millions of dollars, and then all of a sudden it's like, my family's coming out of the woodworks and I have all this money and I don't know what to do with it. And we're super stressed. We may want a child and have tried so hard to have a child, and then that child is born and we're like, oh my gosh, how am I a parent? I don't know what to do. So we're happy, but it's still stressful. Neurotransmitter, one of our big ones, is serotonin. It's more active. And when we see that serotonin synthesis, and during times of stress, we get more serotonin, but however, the stress-activated turnover serotonin is caused by corticosteroids. So that actually leads to some dysregulation in how our brain can use that serotonin. Immune system, we do see a big link between the immune system and stress. There is evidence that stress changes the immune system. And more often than not is a malfunction, and we are not able to fight off illness and sickness as frequently or as good as we used to be. So what are some things that cause stress? Well, we have physical stressors, trauma, excessive cold, heat, hemorrhage, hunger, pain, just different things that happen to us. We also have psychological stressors, divorce, loss of a job, debt, death of a loved one, retirement. Remember, it's both that eustress and that distress. So it could be those positive stressors. A big one with stress is the perception. How you see the stressor indicates your response. Some people, if we were to take someone from like Siberia where it's really cold and put them in a situation where it's really cold, it will not stress them out. If we take one of us who've pretty much lived in Texas for a while where we're used to like 110 and put us in the cold, that will in turn stress us out. So how we see the stress involves how we respond to it. We have something called temperament, which is very much childhood vulnerability, childhood experiences, coping strategies, all of that linked into one. And it kind of just makes us who we are. We have some people that are just always positive. Everything's going to be great. And they may handle stress better than that negative Nancy who's like, this all sucks. Nothing's ever going to get better. Social support. Strong support from significant others, from family members, from friends can enhance mental and physical health and act as a buffer against disease. Culture. Each culture is going to emphasize certain problems more than others, and they're also going to interpret emotional problems differently. Spirituality and religion, they tend to help people cope with stress. Religion often promotes hope and optimism, but again, it's going to depend on your religion. So what do we as nurses need to know? Measuring stress. You have something in your textbook called the Social Readjustment Rating Scale, and it basically looks at in the last 6 months, what changes have you had? Add them together. A score of 300 or more is high stress. That's the Recent Life Questionnaire. I'm backwards. The Recent Life Changes Questionnaire is a 6-month where you look at it. What has happened in your life? And the more that has happened, the more changes, and they're not always negative. It could be positive changes equals the more stress you are under. Now, again, if looking at this Recent Life Changes Questionnaire, if y'all go through it, not all events are perceived to have the same degree. Things that are stressful to me might not be stressful to you and vice versa. We also have to take in cultures, and we all have different thresholds. The questionnaire, that Recent Life Changes Questionnaire, is essentially equating change with stress. But there's so much more to it than that. So when we are looking at stress as nursing, we will have 4 coping styles. Health-sustaining habits. So health-sustaining habits are things that we do to keep our body healthy. Eating good, drinking water, exercise. Health-sustaining exercise, and we'll talk about this all quarter, a great one is walking. Just get out 20, 30 minutes, walk a day. Life satisfaction. Are you happy with your life? Family, work, hobbies, humor, spiritual. Social supports. Who do you have? And what are your coping skills? What are those effective and healthy responses you have to stress? Because they could also be negative responses to stress. So when we manage stress through relaxation technique, we talked about some of these when we did complementary and alternative medicine. Some of these are going to be new. Biofeedback. Biofeedback, if y'all have a smartwatch, it is as simply, most of our smartwatches have a app where it's like, let's look at your breathing and let's look at your heart rate. Take some deep breaths and we can see our heart rate lower. That would be biofeedback. We are looking at our heart rate, our blood pressure. We are doing relaxation techniques and we can see the impact that they have on the body. Now, like I said, using our smartwatches is the simplest. If you were to go to a clinic for biofeedback, they're going to be looking at like your temperature and your heart rate and your respirations and your perspiration and all of these things as we do these relaxation. Deep breathing, we'll go through some exercises in class, so hopefully you'll have a better idea, but it's simple. Take some deep breaths. Guided imagery, we've talked about. Progressive muscle relaxation. I'll post a script for this for y'all, and it is very much, the way I learned it is like start at your toes. Lay down, sit, let your body go at rest, and then you kind of scrunch up your toes and tighten your toes, and then release your toes. And then scrunch up and tighten the muscles in your foot, and then release them. And you work through your body tightening and then relaxing our muscles. And kind of as you slowly get up and get to the top and you crunch up all your muscles and then let them relax, you have a sense of peacefulness. We've talked about meditation before, so that should be one y'all are familiar with. So other relaxation techniques, exercise, 20 minutes a day, a few times a week is great. Um, Cognitive reframing. We've talked about this even if you don't realize we have. This is very much that cognitive theory. I'm not good at this. I'm never going to learn to ride a bike. And then we change it. That's that use of that word yet. I'm not good at riding a bike right now, but with practice, I will get better. And we change that negative thought into a positive. Journaling. Journaling is amazing because it helps take our mind off what we're doing. All of these stress relaxation techniques are just ways to not focus on what the stressor is. It just makes us feel better. Humor, being able to laugh. If we can laugh, we feel happy. And it kind of is that right, laughter is contagious. So now what happens when we have anxiety that is not controlled? We wind up with an anxiety disorder. And anxiety on its own, apprehension, uneasiness, uncertainness, dread from a real or perceived threat. Perceived is always the tricky one. If we don't know what's going to happen, that in itself is anxiety-based. Fear, there is a specific danger. If there is a lion staring at me, that is fear. If I am really nervous about how I'm going to do on this test today, I might fail. That would be perceived because I don't know what's going to happen. I have that uncertainty. I have that dread. Anxiety is normal. We need anxiety to survive. Without anxiety, we cannot do it. And in part because if we have that little bit, that mild anxiety, we problem solve better. If I was like, this class is super easy, it does not matter, I'm just going to get an A, I wouldn't study. If I'm nervous about the class, I'm going to study more. Moderate anxiety, we start to not be able to pay attention to everything. We're not thinking. We do have pretty good problem solving, but it's not the best. Mild anxiety, great for problem solving. Moderate anxiety, not so much. We start to see our sympathetic nervous system come into play. Severe anxiety, our perceptual field is reduced. So if I have a lion chasing me, probably somewhere between severe anxiety or panic, hopefully it's severe anxiety because I'm going to be focused on the lion. I'm going to have this feeling of dread. Oh my gosh, this lion's going to eat me. I'm not going to be able to concentrate on anything else in my environment but the lion. And I'm going to be acting automatically. I'm going to be running. I'm going to have that headache, that nausea, the dizziness. My heart's going to be pounding. I'm going to be hyperventilating. Panic attack is honestly past severe. And this is, they cannot process any reality. We honestly oftentimes confuse panic attacks with heart attacks, with strokes. Our patient is just completely disorganized. They cannot process anything. And what's important to remember if we're going to look at these nursing wise is when we're at this panic level, this is not the point to be like, calm down and take a deep breath. We very much need to support this patient because they can't do anything. As we go from panic to severe to moderate to mild, when we get to that mild stage and we have calmed down, and oftentimes if we're talking panic, it might be with medications. That is when we start to do the assessment, talk about coping skills, talk about support systems, because in that panic stage, there is nothing I can do but be there to support the patient, maybe give them medications. So we have defenses against anxiety. Some of them are called defense mechanisms. These are very much Freudian. It's an automatic coping skill that comes in to just decrease those negative feelings. They can be used healthy or unhealthy. We'll go through these quite a bit in class. I don't necessarily want to go through them too much here. Some of our very simple ones that we tend to see, regression. We're going back to a more childlike state. I have a child and they get a new baby brother, so they start sucking their thumb again. Regression could also be we have someone going through a divorce and they move back in with their parents and now they're going out and partying like they're 18 again. So it doesn't always have to be childhood, but moving backwards. Identification. We want to attribute characteristics to another group. So an 8-year-old wants to be a teacher. She thinks her teacher is awesome. So she starts dressing up and acting like her teacher. That's a positive use. A negative use, We think the neighborhood pimp with a lot of their money and drugs is cool, so we start imitating the neighborhood pimp. I don't know where they get these examples from. Some of them are really funny. Disassociation. We are able to separate ourselves. Disassociation is very much like daydreaming. We get disconnected from reality. Denial is a super simple one. I don't have a problem. Compensation. Compensation, I had a student compare it to a chihuahua. A chihuahua is a super tiny dog. However, they have that really loud bark. And the chihuahua is making up for its small size by their bark. We have quite a few. Like I said, we'll do an activity. I'm not going to go through all of them. If you have questions about them, let me know. So when we look at our anxiety disorders, we do see some common elements in anxiety disorders. It does interfere with personal, occupational, and social functioning. We do tend to see rigid, repetitive behaviors come into play to control anxiety. They tend to be long-term, persistent, and disabling. We do tend to see clusters in family. Very often in mental health, you'll hear me say if we have a first-degree biological relative. That gives you a higher likelihood of having the disease than a family member. We see the amygdala play a role in the brain. With anxiety, GABA is often the focus of our pharmacological treatment. GABA slows our neuron activity, which plays a role in lowering anxiety. Too little GABA and you suffer from anxiety disorders. So a lot of our benzos are going to work by increasing GABA. We have some theories, and we're just going to be very basic. Freud, anxiety is very much unconscious when some of these things from our unconscious are pushing into our conscious. Sullivan is our how we interact with other people theorist. He honestly talked about how it's contagious, how it very much is transmitted from the mother to the infant or to the caregiver to the infant. And if we have a more anxious mother, that child is more likely to be more anxious. Behavioral theory, it's learned from a response. It's learned from a stimulus in your environment. So if you were to come to class and I was like, put everything away, we're going to have a graded pop quiz today, you all would panic. That is behavioral theory. Cognitive theorists, distortions in our thoughts. We have that negative thought to a positive. Cultural considerations, we just have to remember that everything's going to be different. And each of our patients, depending on their culture, is going to present differently and have different things that stress them out, or how they respond to it. Some may be more somatic, and they're going to complain that their anxiety is causing their stomach to hurt. So a few different disorders. We're going to talk about separation anxiety disorder. If you have a little kid, right, let's say 2-year-old, and it's their very first time going to daycare, we're going to expect them to cry and have that separation anxiety. However, if it continues, and now we have a 17-year-old, and they still cry if they separate from us, and that's an extreme example, that is that separation anxiety disorder. It is developmentally inappropriate concern over being away. It could be maybe something happened and we have a spouse who does not want to separate. I panic if I have to leave my husband's side. We have something called panic disorder. And panic disorder is repeated panic attacks that sometimes come out of nowhere. And we have a lot of those physical symptoms with panic attacks, not just psychological. Panic attack very often winds up with that, I can't breathe, there's an elephant sitting on my chest, I can't focus on anything around me. And in that moment with that patient, safety. We want to keep them safe. We want to look for physical symptoms. Even if I'm on a psych unit and I have a patient with a known history of panic attacks and he comes to me and he's complaining of chest pain, I'm calling 911 because I need to rule out a heart attack. I need to rule out that's something else. So we have to keep the patient safe in a panic attack. We have to assess their physical symptoms. Once panic resolves, once our patient goes to mild, then we start the more psych nursey things. We're going to talk about your coping skills. We're going to talk about your thoughts. We're going to talk about triggers. But I cannot do that in the middle of a panic attack. Now, we have something called agoraphobia, and we often see panic disorder with or without agoraphobia. Agoraphobia often gets kind of lumped in as a fear of like open places, but more so it's a fear of being in those open places and you might not be able to escape. So in my house, I am safe. Nothing hurts me in my house. But if I go to the grocery store, there could be a mass shooting and I can get hurt at the grocery store. Or maybe something might happen and I'll get embarrassed. So individuals will stay home because home is safe. I can't be embarrassed. No one's going to hurt me in my house, but in public, I might get hurt. We do have a bunch of specific phobias. Y'all, I would not try to memorize every single phobia. Arachnophobia is one we're very common with. We've already talked about this quarter, that fear of spiders. Aerophobia, fear of spiders. Emetophobia, I think I might be making it up. Something like that is like a fear of vomit. There is everything. There is a fear of zippers and there is a fear of buttons. So if you can be afraid of it, we have a phobia for it. So please do not try to memorize all your phobias. You would be there for days. Social anxiety disorder. Social anxiety disorder is very much, we have a fear of social exposure. If I have to go to Starbucks and I have to go inside the store and order my coffee, I might say something stupid. And I am going to so hyper focus on the fact of like, what am I going to say? The Starbucks barista is going to ask me my name. I'm going to forget my name. I'm going to be like, give some stupid response back. They're all going to make fun of me. And we have a whole bunch of reasons for why social anxiety can occur. We can see that little infographic, traumatic events, harsh parenting, if we're isolated, changes to brain structure. But we're just really nervous in how we're interacting with others. Generalized anxiety disorder is a big one. This is someone who is anxious all of the time. Everything makes them anxious. There is nothing that does not make them anxious. We see a lot of physical symptoms in generalized anxiety disorder, insomnia, because at night when everything gets quiet, that's when our brain can work. We see irritable bowel syndrome. We see hypertension, stress, and heart disease go hand in hand. Is when you're in that prolonged period of, oh my gosh, something's going to happen. It very much is with these patients. These are patients we have to be cautious with because when we talk about benzos, when we get there, our benzo addiction, if we give someone with generalized anxiety disorder a benzo, they're going to wind up taking them continuously throughout the day. They will very much get addicted because the anxiety is so bad that they're going to keep taking it and keep taking it and keep taking it to lower it. But because they're anxious 24/7, they are now taking benzos 24/7. Generalized anxiety disorder needs those long-term treatments. If I have a patient with generalized anxiety disorder and they are in distress, a lot of it is going to be how we interact with that patient. We want to speak calmly. We want to speak slowly. We want to give them brief directions. Hey, thank you for being here. Let's go sit and talk. We're not going to give them multi-step directions. The client at this point in time is not in control. They have no control, especially if we're talking about distress, over their thoughts, over what is happening to them. And we really just need to understand that this is traumatizing for them. There is no positive, and we need to help them walk through it. Clinical pictures, other different disorders, substance-induced. Alcohol decreases GABA. GABA is our neurotransmitter with anxiety. You drink alcohol, you get anxious. If I take away the alcohol, your GABA can eventually stabilize. It can take like 2 years, but it can happen, and the anxiety goes away. If we're talking about something that's substance-induced, if I take away the substance, the condition goes away. Anxiety due to a medical condition, you have a lot of pain and you're really worried about it. Hypothyroidism. The thyroid is a great example because a hypothyroid patient may present and look like they have anxiety. Obsessive compulsive disorder. You will mess up OCD because when you have a type A friend and you're like, oh my gosh, your stuff is so neat, you're so OCD, that is not actually OCD. OCD is ritualistic behaviors. So what happens is patients with OCD get this thought into their head. It's an obsession. I watched a great documentary, maybe when some of y'all were infants. It was about 17, 18, 19 years ago about OCD. And there were individuals who, when they were driving their car down the road, they were like, oh my gosh, I hit a bump. I just killed someone. So every time they drove their car and they went over a bump, this thought would get stuck in their head that they cannot get rid of. It is called intrusive, that they just hit someone with their car. So that thought creates anxiety. To stop that anxiety, this patient then has a ritualistic behavior. So they stop the car, they get out, they walk around the car to make sure they didn't hit anyone. This patient then goes back on with their life. However, the next time they hit a bump, the thought goes into their head, they stop their car, they get out and walk around. And it repeats itself every time this happens. OCD, we talk about hygiene, we talk about frequent hand washing. I have met some homeless, very dirty clients with OCD though. It's just going to depend on the patient. We do have what's called exposure and response prevention. This is when our first line cognitive behavioral interventions for it. The patient is exposed to a stimuli that triggers their OCD patients. So if we have a patient who is afraid of contamination, they're afraid of touching things, we might have them touch a doorknob. However, we're then going to have the patient prevent themselves from performing the ritualistic hand washing. And the whole point is we want the patient to learn that anxiety is going to subside even if the ritual is not completed. So we try this in the office with the patient. They gradually learn to set limits, and then we slowly increase how long between the obsession starting and the ritual, and hopefully the urge will fade away. So more different types of disorders we'll go through fast. We talked about OCD. Body dysmorphic disorder is not always related to eating disorders. It very well could be my ears are different. Do you see that my right ear and my left ear look different? I need to go have surgery to make my ears look the same. The individuals who are like, I had to take my ribs out and slit my tongue and get my eyes painted color so I look like a snake. That just makes me feel better. Hoarding disorder, I can't throw anything away. But I might need this one day. Hair pulling is very much related to OCD. It is called trichotillomania. And I'm anxious, so I pull my hair out, and that compulsion of pulling my hair out lowers my anxiety. We also see a skin picking disorder called excoriation disorder. Now, I know we all pick at our cuticles, but in excoriation disorder, like this patient is like, the skin is missing, they are bleeding, it is bad. Other compulsive disorders, we can talk about kleptomania. I just have this compulsion to steal stuff. Pyromania, I have this compulsion to just light things on fire. So our nursing process, we always have to look at symptoms and we have to face Maslow's. If my patient has a panic attack, I have to rule out a heart attack. I have to look at safety. Is my patient safe? What can I do to keep them safe? Can I take them somewhere safe? All of those different things. Nursing diagnoses, outcomes planning, it's honestly all, we won't go into it now here because it depends on your patient. So in that assessment, have to do a good neurological exam, rule out everything we can. What is the source of the anxiety? Did something happen? And that would be more a secondary cause. Is it a medical condition? Is it substance abuse? That would be a secondary cause of anxiety because I take away the alcohol, anxiety decreases. Or is it primary where anxiety is just innate in this person? What's their current level of anxiety? We will always assess for self-harm. Psychosocial can be helpful because if you are struggling in school, if you're struggling with your finances, if you have legal difficulties, that is all going to increase their anxiety. Self-assessment, so looking at ourselves, is honestly really important here because of that anxiety is contagious. If we have a situation, and it does not have to be a mental health, y'all, but we're like anxious and our patient can tell that we're anxious, that's going to make our patient more anxious. So we have to kind of fake and portray that calm exterior even when we're nervous. So again, I'm not going to go too well into nursing diagnoses over here because we got slides. I want to get this done in an hour, but here they are. So depending on anxiety, it says patients don't require inpatient admission. It depends on what's going on. Anxiety on its own won't get you an inpatient stay. We're all a little anxious. But if we can't do our ADLs, if we are a danger to ourselves or someone else, that is that criteria. We want to do everything we can in the community. We want to get the patient to participate. However, severe levels of anxiety, this patient cannot participate in planning. We will be the ones planning their care and kind of bringing them along for the ride. So panic, severe, they're not planning their care. When they get to mild, then we can start to implement that. Our application of the nursing process is really going to depend on what level there are. We've already talked about this severe and panic. I'm going to be doing more of the care for the patient, help supporting them, more focus on meds. Well, mild to moderate, we're going to be assessing coping skills, teaching deep breathing, talking about relaxation techniques. Everyone needs counseling. If you have anxiety, you need counseling. And meds, and I say that because meds work and I can give you anti-anxiety meds, but the meds alone are not going to solve the problem that is going on. It is like putting a Band-Aid on a big open wound that probably needs stitches. It might eventually heal, but you're going to have this nasty scar and it's not going to go well. And then the next time something happens, does the scar tissue split? So we want to get all of our patients into counseling. Teamwork and safety, if there is something safe with our patient, if they're in a crisis, if we think they're suicidal, if any of this is going on, we just got to keep an eye on them. The same basic stuff we will talk about all quarter. Promotion of self-care activities. I want my patient to get up and to shower and wash their hair because that just makes you feel better. When we go through some of these, that patient in panic or chronic severe level, they're not going to be able to do it on their own. When they get to mild, then we can get them to do it. Pharmacological interventions. Okay, y'all. I'm going to pause here and switch to a little bit different of a PowerPoint where I have some different slides on pharmacology. Okay, so we have a few different classes of meds that we can use for anxiety. Benzodiazepines are one of our oldest. They're fast acting. They work for everyone, but they're short acting. So you're having a panic attack. I give you a benzo. You feel better in 30 minutes to an hour, but it's only going to last like 6 hours. If I have someone who's afraid of flying and they have to get in an airplane, great, let's give them a benzo. My generalized anxiety disorder patient, again, we don't want to give them a benzo because they're going to take it all the time and we wind up with addiction. And benzo addiction is so horrible to try to get these patients off of benzos. They were some of the hardest patients to detox. If you stop taking benzos, and we have had someone who has been taking large amounts for a long period of time, we get extremely bad withdrawal symptoms. Talking about like 200 over 100 and some odd like blood pressures. It is very bad physically. I had a patient who was withdrawing from benzos once. He was doing opiates too. Not a lot of opiates, mostly benzos. And he was in the hospital trying to get his blood pressure stabilized for a few weeks. Benzos on their own don't cause extreme respiratory depression. It is not like our opiates. I give you an opioid, I suppress your respiration. Benzos cause respiratory depression if it gets mixed with something. So if we're drinking alcohol, doing opiates and benzos, it's just a higher risk. It's going to be faster to suppress those respirations. We do, because of that respiratory depression, have to use caution: elderly, COPD, and sleep apnea. It causes sleepiness. It causes drowsiness. I don't want to give this to someone and send them out driving a car. Caffeine. Caffeine is bad with benzos. If we have someone who is a coffee addict, very much me, you don't want to give them benzos because benzos are sedating. Caffeine is activating. It's a stimulant. So now they're counteracting each other and not doing any good. Buspirone, and this gets hard, y'all, because benzos and buspirone both start with B. Buspirone is a long-term. Benzos, we give PRN. Buspirone, also known as Buspar, we do not give PRN. Take it every day. You don't get the sleepiness or muscle relaxation that you do with benzos. They're not addicting, but they do take a few weeks to work. So these are very good for someone with generalized anxiety disorder when they need a little bit more support. We will go into specifics about all of these classes of medications, these on the right, the SSRIs, later. But all we're going to know now is we have other choices of meds. SSRIs are oftentimes a first line for anxiety, generalized anxiety disorder, panic attacks. Beta blockers are often a first line for social phobias. Antihistamines. I had been a nurse for almost a decade before I realized that hydroxyzine, something called Visceral Atarax, was an antihistamine and not an anxiety med, because we use those antihistamines so frequently in psychiatry. This is a short down and dirty on the meds that we need to know on anxiety. I'm going to switch back to our original PowerPoint now. Okay, so we talked through pharmacology on our different slide. We're focusing on that benzos and we're focusing on that Buspar. Other psychobiological interventions, we've kind of seen this when we talked about it. We have some different substances that we can use, herbs, supplements, a lot of our integrative therapy. Health teaching, we've talked about, we want to do, right, that 30 minutes of exercise most days of the week, 5 to 6 days, 4 days. We want to eat right. We want to make sure we're sleeping. All of those things make us feel better. Cognitive therapy, we want to change that negative thought into a positive thought. Behavioral therapy, we've talked about a lot of these before. We want to teach relaxation technique. We want to model good coping skills. Systemic desensitization. You're afraid of a spider, and I'm going to slowly expose you to spiders. Here's a picture. Here's a cute little stuffed spider. Let's watch Charlotte's Web. Here's a realistic looking spider. Flooding. You're afraid of spiders, and I'm going to throw you in a room full of spiders and just lock the door. And we're just going to overwhelm you with spiders, so eventually you're not afraid. Response prevention, that was that one we talked about, exposure and response prevention with OCD. Hey, if your OCD relates to contamination, I want you to touch this doorknob, and then I want you to wait. How long can you wait before you wash your hands? And we want to teach that patient that eventually it does go away. Thought stopping, we just stop the negative thought. Cognitive behavioral therapy, I want to change the negative thought. We want to become aware of it. When we change those thoughts, we change our behaviors. How is the patient doing? We evaluate anxiety on a scale of 0 to 10. On a scale of 0 to 10, just like we would pain, how bad is your anxiety? 0 being none, 10 being a panic attack. Does the patient recognize their symptoms are anxiety related? And you'll see this more when we talk about somatic disorders. Are you complaining of IBS type symptoms, or are you complaining of insomnia, but you think you just have insomnia? You don't realize that it is the anxiety staying you awake. Are they continuing to show signs and symptoms? Is our patient with trichotillomania pulling their hair a little bit less? Or is it getting worse? Evaluation. Are they able to use those coping skills? Did we teach them new coping skills, and can they now use them? Can they do self-care? Can they maintain relationships? Are they able to do their roles? This is very much a lot of what we talked about when we said what is mentally healthy. We have some scales that we can use, and we want to see those anxiety scores increase. I'm not stopping. We're going to crisis and disaster. We got a lot, so we're going to keep going. So crisis and disaster. This kind of grows on anxiety and stress. A crisis, disturbance caused by a stressful event. So in crisis, our normal coping mechanisms fail, which means we cannot function as usual, and our equilibrium is replaced by disequilibrium. Crisis, again, just like stress and anxiety, is based on our perception. But it also allows us a time for growth, and it tends to be short-term and acute. This very much is hey, these different pathways could happen. We have a stressful event, we go into disequilibrium, our body wants to be in homeostasis, so we try to restore equilibrium. If we can do it, then the crisis isn't really a crisis for us. If we cannot do it, if one of these things exist, we wind up in crisis. Talk about it as we go through, but this is kind of a good flow sheet that sums it up all together. So it depends on that crisis. What is my individual perception? And it could be realistic to distorted. The example Galen gives me, we have twins, Annie and Amy, and their parents are divorcing. One twin grades plummet, she becomes despondent, she has trouble sleeping. The other twin tells her friends, I'm going to get a new room to paint. Not always the best example, but that's kind of what we see. Do we have situational supports? Who are the people who are able to help? It's not always even friends or family. If your house is on fire and you call 911 and the fire department comes right away, that is helping end your crisis, right? You have a small kitchen fire, you call 911, 911 comes, the fire department puts out the fire, part of your kitchen is damaged, but honestly your house is still livable. You had support and it helped. Do we have nurses? All of those things. What are our coping mechanisms? Are they healthy or unhealthy? We didn't talk about it too much in this recording, but we want to have adaptive, positive coping mechanisms. And we do not want those maladaptive. So is our patient drinking a fifth of whiskey because of the stressful event, or are they able to go on with it? we have a few different crisis theories. We're not going to go into them too much here, but behavioral responses to crisis are normal. This is very much what it is. Crisis happens. This is our pyramid of crisis planning. We assess the crisis. We build trust with the patient. We identify major problems. What is going on with the crisis? What is the perception of the crisis? We start talking about feelings, and then we explore options. What is going on? What can our patient do? Come up with a plan, and then we continue to follow up. It'll all make sense, I promise. So we have a few different types of crisis. Maturational crisis is very much Erickson, and it linked to his 8 stages of growth and development. So each developmental stage represents a developmental crisis. When the crisis is overcome, we tend to continue to grow and develop at that point. So we get to a new stage, we don't have the coping skills to deal with that new stage, so our defenses are less. We continue to try to learn how to grow and overcome, and when we do, we keep growing. So when we talk about maturational crisis, these are things that happen throughout the course of your life, and they're almost like normal and expected. We expect that we're going to move out of our parents' house at some point in time, right? Marriage is kind of a normal part of life that eustress versus distress, but marriage can still be a crisis. Having a child, retiring. If we have an elderly parent and our 93-year-old grandmother passes away, that would be a maturational crisis. Grandma's 93, and as horrible as it is to say it like this, we expect that she's going to be passing away soon. It will not be a shock. Those are a lot of those maturational crises. A situational crisis is sudden and unexpected. However, they are not, these are things that we may happen in the course of a life, but we were not planning on them. So if I have the death of my husband, right, 40 some odd years old, he just all of a sudden passes away, that would be a situational crisis. Sudden change in financial status, a divorce, I get into a car accident and I break my leg. These are things that arise, they're external to us and they're sudden, are situational. Maturational, we more so expect to happen. Adventitious are our big ones, and confusing adventitious with situational and situational with maturational tends to happen. These are generally, we're going to think catastrophic, right? Completely unplanned. Earthquake, massive hurricanes, war, riot, airplane crashes. All of those would be adventitious crises. So we have a few different phases of crisis. In our first phase, we are confronted with a conflict or a problem, and it is threatening our equilibrium. That is very much that first stage. We respond with increased anxiety. We're trying to use our problem-solving techniques. We're trying to keep our defense mechanisms in order to address the problem and lower our anxiety. So we are using those problem-solving techniques and defense mechanisms. Sometimes we can resolve the problem. In phase 2, my defense mechanisms fail. The threat's continuing, my anxiety is increasing. I am trying to trial and error. I'm trying my best to restore balance with new type of coping skills, with new things, and hopefully it helps. However, in phase 3, the trial and error fails. Our anxiety can increase to severe or panic. We are mobilizing fight or flight. We are trying to make some form of resolution. Maybe we're compromising, redefining what is going on to see how it works. In phase 4, my coping skills are ineffective. I am completely overwhelmed with anxiety. This is often when we're going to see admission, if we're talking about to a psych unit. Phase 1, phase 2, phase 3, I'm trialing my defense mechanisms. I'm trial and erroring new things. But when I get to phase 4, my coping skills are done. Violence, confusion, suicide, harm to others. These patients are completely disorganized. So when we look at the nursing process, the assessment, very much focused on safety. How can I keep you safe? Are you having thoughts of hurting yourself? Are you having thoughts of hurting anyone else? Do you feel like you can keep yourself safe? We do have to look. So we're going to assess safety. Then we're going to start looking at perception of the event. Then we go to situational sports. Then we go to coping skills. We always, again, have to do that self-assessment because it's hard for us. So when we're assessing our patient, we're going to assess for safety. We're going to assess for their perception of the precipitating event, their supports, and coping skills. Safety always wins, y'all. Safety will always win. And we always have to assess ourselves. These are some of our nursing diagnoses with some signs and symptoms we can see and outcomes. These are very good to look at just to get an idea of what we're going to see, but I am not going to take the time to go through them now. One of our primary nursing diagnoses that we do see is ineffective coping. Something's happening and our coping skills are not effective for the situation. Outcome is again going to be individualized to your patient. Planning, we're going to teach coping skills. We're going to teach about hotlines. We're going to refer to group therapy, anything that involves patient safety or anxiety reduction. Like that is what we are doing. We do tend to see this primary, secondary, and tertiary prevention. It doesn't go away. Primary, I want to promote mental health to decrease the incidence of a crisis. If everyone has really good coping skills, it is less likely a crisis will happen. Secondary, we want to, as the crisis is happening, we want to be able to utilize more coping skills. We want to be able to get in there as nurses and start working with these patients to lessen the time that they are in a crisis. In secondary, the crisis is happening, but we're working with them from the beginning. Tertiary, the crisis is over. We want to keep our patient in therapy to keep them from getting worse. And evaluation is always just going to depend on what is going on with your patient. So we have some interventions we might use. We're always going to assess for suicide. That will always be first. We're going to make sure our patient stays safe. We're going to use that therapeutic communication, therapeutic use of self, listen to the patient. We may have a crisis intervention. Do they need babysitters? Do they need food? Do they need clothing? It will very much be based on Maslow's what is going on. We then look at social support. Who is involved with this patient that can help them? We try to teach new coping skills. We then have to look at what the patient can do. This is kind of like a backwards Maslow's. We're at this involved patient identifying realistic, acceptable interventions. That's kind of like at the tip. We're safety, we're food and sheltering, we're looking at social supports, we're then getting into self-esteem, and then we're looking at that self-control. How can we get this patient going on? One of the biggest things in crisis is that regular follow-up, staying in contact with the patient, looking at their progress, making sure it's going okay. We have a few different modalities: emergency rooms, telephone hotlines, peer crisis service, intervention teams, stabilization beds, short-term. These are all different places. Our patient can call 998. We have even something called a warm line, which is not a suicide hotline. It's similar to a crisis line, but it's more so you just need someone to talk to. We're trying to prevent an escalation of distress. So when we talk about disasters, this is very much more a community health topic, but we're going to cover it too. This is large-scale global. Tsunamis, hurricanes, wildfires. I like how it says the stock exchange collapses, but these involve more than just one area. We very much have to look at the community. There is a lot of planning that goes on at the FEMA level. There are different coordinations. I honestly did this a lot as part of my job in the Army Reserves. We could talk about this for a while. It's called DSCA in the military, Defense Support of Civil Authorities, and how we come in. Everyone has different roles and everyone has different jobs. So we have to look at what's going on at that local level. We have to network in the community, and then we have to try to connect national programs. The biggest thing we want to do is be prepared. FEMA runs all types of these exercises, and you can actually petition for them to come into your area. And they will do this there's one in Georgia every year related to chemical attacks on the country. So we want to do these exercises. We want to be prepared for it. Mitigation, we want to limit the disaster's impact on human health and community function. We want to kind of nip it in the bud, and that preparedness and mitigation go together. What can we do to reduce the risk? Response, the disasters happen. how are we implementing our disaster plan? Does it go okay or does it not go okay? Recovery, the disaster is kind of over. We're now focused on stabilizing the community. We want to bring you back to where you were before. An evaluation should always come. Did we do the right responses? Did it go okay? We're all more familiar with COVID. The U.S. government, the U.S. military, Army at least, had no flu pandemic, respiratory pandemic type plan. It was all very much knee-jerk reactions because we pretty much just reevaluate our plan from the backside. So the government went in, we set up at the Javits Center. We're like, sure, this will help. And then we realized this is not going to work. So we closed down that Javits Center in New York. And then we looked and said, why did the Javits Center not work? That was a lot of even COVID. We saw a lot of these steps happening within the government. The Department of Homeland Security coordinates the response of U.S. disasters. We will oftentimes use civilian first response professionals. There are volunteer organizations. There is one in Austin where you can volunteer within Austin if it's like a, hey, I want to volunteer, and let's say there's a hurricane, and they will mobilize civilian responders to help with that. We want to make sure we just have everything going and have communication. You normally have one incident commander who then kind of coordinates down. But that's disaster management at that level. And we're done, y'all. Took me 51 minutes for Unit 4. If y'all have questions, let me know.